Good evening and welcome to our SafeScript training presentation. Thank you for joining us at the end of a busy and hectic day, I'm sure. Firstly, I would like to acknowledge the traditional custodians of this land. I would also like to pay my respects to their elders past, present and emerging, and extend that respect to any other Aboriginal people present today. My name is Anna McIntyre. I'm a pharmacist and an educational visitor with NPS Medicine Wise, and my fellow presenter this evening is Dr. Mark Davies, a GP here in Geelong and with a special interest in alcohol and other drugs. Just a note at the start, for all the GPs and pharmacists who've joined us tonight, there will be information at the end of this session in reference to receiving your RACGP or ACRM points, so stay with us then. So the outline of today's session is, firstly, we will have a video outlining what the SafeScript program is about, and then the rest of the training is split up into 3 sessions, looking at what is SafeScripts, looking at the high-risk medicines and clinical practice, and then looking at challenging conversations. And we will have people are able to submit questions and we'll do our best to answer those as we go. So the learning outcomes for today, firstly to list the key rationale behind the introduction of the SafeScripts, of how to monitor the supply of the high-risk medications, how the SafeScript system integrates into your workflow, be able to describe the considerations that you take into account when supplying the high-risk medications, identify the appropriate steps to take when concerns arise about the safety of the high-risk medications, and identify the elements and components of the best practice communications when we're discussing the high-risk prescriptions with our patients. So, introducing the SafeScript program. So we'll have a short video that we will show you now. So we were just saying that SafeScripts is actually a real-time prescription monitoring system that enables high-risk medication prescription records to be stored centrally and accessed by prescribers and pharmacists directly during a consultation. It is not a clinical tool. It is a clinical tool to inform the clinical decisions for the prescriber and the pharmacist. So it does not take away your ability to make the decision, but it's simply a clinical tool to help you. And it also enables the facilitation and the early identification and treatment to support those patients that are showing signs of potential or existing high drug use. Okay, so if we can have the video now.
Safer patient care is only a click of a button away. More Victorians lose their lives from prescription medicines overdoses than on our roads each year. This is an opportunity for us to do something to make a real difference. SafeScript, a Victorian government initiative to help health practitioners provide better care to patients on high-risk prescription medicines. It offers comprehensive information on the prescription history of a patient, including helpful alerts to prompt clinical intervention when the patient may be at risk of harm. It's quick and easy to use and updated in real time, allowing health practitioners to work together to better treat their patients. In conjunction with additional training focused on improving clinical and counselling skills, SafeScript will help health practitioners to coordinate care and identify patients who need additional support to manage their medicines. Using SafeScript is easy and secure. After a once-off registration, which includes important security settings to protect patient health information, you'll be able to log in and refer to a list of monitored medicines prescribed and dispensed to your patient. As health practitioners, this is your opportunity to be at the forefront of change. SafeScript is easy to use, safe and secure, but more importantly, it will save lives. Go to www.health.vic.gov.au/SafeScript to sign up today.
So just to give you some background information on the SafeScript program, It was a pilot study that was commenced in the Westvic PHN in October 2018, and then it was available to all PHNs in Victoria from April 2019, and it will be mandatory for all prescribers and pharmacists to access the SafeScript portal from April 2020, so just in about 1 week's time. So there is a SafeScript training hub, and there are also online learning modules. Now, the learning modules are on the NPS e-learning website, and there are 3 modules, and they pretty much take the same format as the sessions that we were going through today. Module 1 looking at the what and where and how of SafeScripts. Module 2, there's a separate one for pharmacists and for prescribers, looking at the high-risk medications and clinical practice, and the 3rd module looking at those challenging conversations. So if you haven't already accessed those and gone through them, I'd recommend it. It's good practice to go through those, and you also get your CPD points if you complete those modules as well. So you need to register to access the SafeScript portal. You just need to register once, and then once you've completed that, you will be able to access the SafeScript portal every day. And the Department of Health and Human Services information site there also is technical support and systems help there. The only thing is, due to the coronavirus crisis at the moment, the helpline at the SafeScript Information Centre is not able to be accessed at the moment, but the technical support certainly is able to be accessed. Now, just moving on to what the monitored medications are. So these high-risk medications that are monitored are all of the S8 prescriptions, all the opioids and alprazolam and flunitrazepam, and then all of the benzodiazepines, also the Z drugs, quetiapine, and any combinations including codeine. Now, these medications were chosen or selected to be the high-risk medications following a literature review conducted by the Austin Hospital, and that literature review was updated in last year. Now, there have been questions as to why pregabalin is not also included on that list, but the evidence for harm is not as great with pregabalin as it is with the medications that are listed, and the evidence of harm with pregabalin is only when it's used in combination with opioids or benzos. And tramadol, and there was another one that was also Lyrica.
So,
yeah. Thank you, Mark. Yeah, at this stage they are not included, but that is not to say that other medications will not be included over time. The medications will be monitored. So what does SafeScripts mean for you? Okay, as I mentioned earlier, it is a clinical support tool. The prescription records are transmitted in real time, and they can be accessed during the consultation while the patient is there with you. So it does not replace clinical judgment, and it doesn't mean that you can't prescribe or can't dispense. It is so that you can see the medication usage by the patient, and that enhances your clinical decision making. So at this stage, we cannot see hospital records. We will talk more about what goes on in hospitals a bit later on.
This is my favourite slide.
This is your favourite slide. It's quite a busy little slide. It's got a nice little workflow diagram here. So as we can see, we'll just walk through what happens with the patient. So the patient comes to see the doctor. Then in the little sort of mauve section at the top, the GP is able to access the SafeScript record when the patient comes to see them, and then they can decide if or not they wish to prescribe that medication. You see the little red triangle there is an alert, which we will discuss as we go along. And then the patient, if he decides that he is going to prescribe, having checked the portal, the patient then moves on to the pharmacy, which is the little red section there. And then again, when the pharmacist puts the information into their computer, they get the notification, the little red alert symbol there again, to decide if they do need to prescribe or not prescribe that medication for the patient, and then also that the SafeScript is being monitored by the Department of Health as well. So those little padlocks that you see in the centre, that's just to indicate that there is security there, data security, so that the patient's privacy is protected as we go along. So I guess the only thing that we need to mention with this is that if for you to be able to access this sort of easily, the SafeScript program is designed to interface with the prescription exchange service, and then that interfaces with the prescribing and dispensing software. Anything there, Mark, that we need to
just
make mention of?
We use best practice at the practice I work in, and it does work very seamlessly. And when you prescribe, say, an opiate, Schedule 8 medication, when you come to press print, it will bring up the SafeScript automatically, and it will come up. And if you need to access SafeScript, just clicking on it will take you straight into the SafeScript website and to that patient's record. So it's slightly different for different software, but certainly most of the software now, best practice, medical director,
ZMed, most of the others,
pretty seamless these days.
So if you've got the latest version of the software, it should be there. And I think the only comment I've had from some GPs is saying that they do have the latest software, but they're not getting those notifications. Is that just ensure that you have in fact clicked the little tick on your software that enables you to access the SafeScript portal. So now we've mentioned alerts and notifications, so we just need to clarify what those terms actually stand for. Alerts exist within the SafeScript portal. So the alert indicates that the dispensed or prescribed medication it has met certain criteria for high-risk circumstance. Notifications are something else that pops up in the prescribing or dispensing computer, and we'll talk about those next. But the alerts, for an alert to be triggered, the situation is that the patient must have seen multiple prescribers having prescriptions from 4 or more within the last 90 days. If they have exceeded the total opioid dose threshold, which is a daily morphine equivalent dose of 100 milligrams equivalent or more, or if they have had a high risk drug combination, that is either having methadone or fentanyl with either a benzodiazepine or a long acting opioid. Now these alerts remain active for 90 days and then will automatically expire from view. That's to ensure that the alerts remain time relevant.
And I think the reason for an alert over 100 milligrams morphine equivalent is that the risk of overdose, accidental overdose, really shoots up, goes up exponentially after that. So we know between 50 and 100 milligrams morphine equivalent, you're at quite high risk.
Yes,
but over 100 milligrams, a lot higher risk of accidental overdose. And at the moment in Australia, we're all more likely to die of an accidental opiate overdose than we are in a car accident. Except nobody's on the roads at the moment, so that doesn't really count, does it?
Certainly. And I think what the evidence is showing us also is that probably almost half of those patients that do die from an opioid overdose are also taking a benzodiazepine. So that high risk combination is really important to take notice of. So the notifications that we see, so the difference is that the notifications are what the pop-up message that appears on the computer screen of the prescriber or the dispensing pharmacist. if assuming that the clinical software is integrated with the SafeScript program. So the notification is either going to be green, amber or red. So a green notification appears when there is no recent history or when the monitored medicines have only been prescribed from a single prescriber. The amber notification will appear when there's information in SafeScript that needs reviewing. So that information will either be multiple prescribers, either being to more than 4 pharmacies in the last 90 days, or again more than one prescriber. Or if the opioid threshold is between 50 and 100 micrograms morphine equivalent per day. And then the red notification is those when there is an alert that we have mentioned in the previous slide. So being the multiple prescribers, the exceeding dose of more than 100 milligrams equivalent of morphine, or those high-risk combinations. Now, Mark, you just want to talk us through what actually happens when that pops up on your screen?
So when it pops up on the screen, fortunately for people like my brother who's red-green colourblind, it does actually tell you what you have to do. So the green notification will say exactly as it says on our slide here. There's no need to check, you can go ahead and prescribe. The amber will say there's information that requires a button and go ahead and prescribe. But when there's actually an alert, you won't be able to prescribe until you've checked SafeScript first. That's when the software is integrated into the prescribing software.
Certainly. All right. I'll just...
So
I think you just want to move on to the slide after this that
Yeah.
talks about the morphine equivalents before we go back to that one.
So it's just interesting to look at what is 100 milligrams morphine equivalent, and we put together the slide there. So it's interesting, isn't it? Oxycontin, Targin, 65 milligrams. So it's a lot stronger than morphine. Tapentadol comes up at 330. These figures are taken from the morphine equivalent calculator, which you can also find on the department website. The buprenorphine patch, 40 micrograms per hour, that's also equivalent to about 100 milligrams morphine equivalent. And the fentanyl patch. So once you're really over the 25 plus a 12.5, that's 100 milligrams equivalent. So it's a very important level that to know about.
Thank you, Mark. Now, we will go into demonstrate how to log into the SafeScript portal. If Mark can talk us through that one, walk us through.
So what we're going to do, we assumed you've been to the department website. We assume that you have your user login and your password. So when you click on the login page on the web, it will take you to this page. Pick an account. So my account here, rather than Dr. Safe, is prescriber.training. So you would click on that. It will take you to a password. So this is your long-term password.
We're still on the PowerPoint, Mark.
Ah, we're still on the PowerPoint. There you go. Wasn't looking up. So we just need to go to settings. Sorry about that, everybody. So what we can do, just as a little exercise while you're all waiting in this time of COVID, why don't you all keep account of how often Anna and I touch our faces? And the winner gets...
I'll have to sit
the winner
on
is the person who touches their face least. And we'll keep
I'll
a
have
little
to sit
count.
on my hands now, Mark, so I don't do it at all.
And we're back. We're back.
Okay.
That's good news. Good news. So I'll just go back one screen. So this is, oh no, my login. Right. So sign in. So I've got to sign. Let's just go forward one. Don't you love technology? Right. So I've put in my username, which will be a username of your own making. So it will be something like drssafe@safescript.vic.gov.au. That then takes you to your password. So this is your long-term password. So it would be a password with a high degree of safety. And then you enter your password. So for the training password,
and you'll see I haven't touched my nose yet. Training 2019. Sign in. So this is exactly what happens when you sign in every day. So you do it every morning. It takes about 25 seconds. I always click don't show this again, but it seems to always come up. So you want to stay signed in for the day. So click on yes, and then it will actually ask you to create a password for that day. It is absolutely fine to use the same password every day. So 6 figures. So, and then go OK, and then it will take us to the dashboard of SafeScript. So you can, so when you go in the morning, you actually can get SafeScript up, and it will be up like this. So when you're looking at a patient, when you prescribe, say, an S8, and it takes you to the SafeScript site, it will take you to that last password. So that just the 6-figure password, so 441144, something like that. And it takes you to the dashboard. Now, when you're actually prescribing for a patient, you will see that patient right here without searching for them. So we're looking at the dashboard, and welcome prescriber training. There's a button here, if you can see the mouse, permits. That will list all the permits that you have as a prescriber. And you can also search for patients. So that's the system. So we're going to look at a patient.
Yeah, I think just, well, yeah, we can.
Or should we go back to the slideshow for a minute?
No, yeah, well, we can do the patient.
Okay.
Do the case study. Is
Yep.
that what you want to do?
Yeah.
Yep.
So we might try a patient first of all, just to illustrate. So we're going to search for the patient. So we go search. So this is very useful. Like I had a request today for a client of the Bio and Opioid Management Clinic who is on some Seroquel. I've lost my script. So I thought, well, rather than just send out another script, I will actually look you up on SafeScript. And I was able to tell from SafeScript that he had not cashed in that script. I could see it had been prescribed, but I could see also that he had not presented it to the pharmacist. So we'll just do, there's a lady here called April Adams.
So we can bring up, just do a quick background on April, just to tell you who she is. So April is a patient that has been to our clinic for several times over the last 3 years, but we haven't seen her for the last 12 months. So at that last appointment, 12 months ago, she was prescribed oxazepam and diazepam for a long-standing back pain issue and moderate anxiety. So we're assuming that the date of today's appointment is the 1st of April 2019, just so that the SafeScript record that comes up makes sense to you. And April has come in and requested a prescription for oxycodone for her back pain, which she says has flared up lately.
So on the surface, that sounds like a very reasonable request. But we're thinking, oh, well, let's use SafeScript and just have a look anyway. This information will come up if we try to prescribe the oxycodone, but it's sometimes very reasonable just to look it up before sometimes people have entered the room. But in this case, April's sitting with us. So we'll just pop in her date of birth. It's very easy. You can pop it in any format and it will come up correctly. So I'll just go 1st of January 1990. Search. So we can see April Adams appears here. Just while we're doing this, another quick way of searching is that IHI number. So in the demographics in your prescribing software, every patient will have an IHI number, and you can just highlight and paste. That's quite a quick way to search for patients. So April Adams, and this will bring up her record. Oh, so what we can see on the screen is a record of her prescribing and her dispensing. You can see over on the right hand side of the screen that prescribers are in blue and dispensing is in green. In the center of the screen is the event type, so you can actually click on this and just choose to see prescribed, only the prescriber. So if we just look at that briefly, we can see, so it was the 1st of April, is that correct, Anna?
It was the 1st of April,
yeah.
Is today's date, yes.
So we can see that April has been quite busy, and she's gone and seen Dr. Brown on the 2nd of the 3rd. She's seen Dr. Black on the 12th of the 3rd, and she's seen Dr. Green on the 20th of the 3rd. So she's been going once a week and collecting 28 tablets of OxyContin. So she's obviously on about 4 tablets a day if she's using all that. We can then look at the prescribing and just see the dispensing and just see actually what's been dispensed. And the pharmacists amongst us will be checking their scripts every time they come in. So again, from April 1st, we're all mandated to check both the prescribing and the dispensing. And we can see that, yes, she picked up her first 28 tablets on the 2nd of March. She picked up another 28 tablets on the 13th of March and another 20 tablets on the 20th of March. So she is clocking up about 2.5 to 3 tablets a day of 20 milligrams, a fairly significant amount. And we know that once you've had opiates in your system 24 hours a day for more than about 2 weeks, you will have a degree of physical dependence, and the more weeks that you clock up, the stronger that physical dependence will be.
So, Mark, now that we've got April's SafeScript record up there, and we see that she has in fact had a number of prescriptions from a number of prescribers there, what's the next step? How are we going to manage this consultation with April?
So clearly we're in a dilemma. So the SafeScript is a tool, so we could choose to carry on and keep prescribing to April, but we do obviously have an issue, and April has an issue here. So what's the best thing to do for April? Certainly showing her SafeScript. There's nothing wrong with showing the patient what's actually on the screen and saying, oh, I can see there's an issue for you here. So then it might be worth asking some questions of April just to see where she is with her understanding of the situation or not. A good question to ask might be, what do you think would happen if you stopped taking OxyContin? It may be that April doesn't realize that the pain she's experiencing is actually withdrawal from the OxyContin or the oxycodone, and not knowing it's withdrawal and not actually the pain. You can ask her, do you find it easy to stop taking the OxyContin? Have you missed a tablet? What happens when you miss a tablet? How do you feel the OxyContin helps you? How do you feel this medicine is helping you? Is it helping the pain? Does it help you in any other ways? Do you find it is, sometimes it's worth asking, do you find it relieves stress for you? Do you find that you feel more relaxed and calmer? Perhaps your anxiety is better. So it's worth getting a whole picture of what's happening to April.
And certainly with April, as she's previously been using benzodiazepines, and even though they haven't perhaps come up in this SafeScript, do we know has she had any at home from the previous dispensings also? That she's had. So yeah, just to try and get a full history, just to ask a few questions from her. So Mark, just before we move on, just going back to the SafeScript screen there, that I think we didn't mention it earlier on, looking at the top tabs where we can also mention that we can view the access history to see which other health professionals have actually had a look at April's history, so which is a useful piece of information.
So we can see for the screen that Dr. David Blaxland has obviously accessed the screen a lot, so he's keeping a check on what's happening. And it also, you can also see that which pharmacist, and talk to the pharmacist if you have to, and the pharmacist can talk to the doctor. So that access history is kept for anybody that accesses April's file. So
they don't have necessarily had to have dispensed or prescribed anything. They've just gone in to have a look.
That's correct. And to access April's file, unless you're involved with her care in some shape or form, is absolutely essential. So So you're not allowed to access people's private information like this unless you're involved in their care or giving advice on their care. And a record will be kept. Just looking at the screen as well, again in that top right hand corner, if we click on the permits, that will actually show if there's a permit in existence for April already. It's greyed out, so there isn't, and there are no alerts for April at this stage of her opiate career, shall we say.
Yeah. And I suppose that just highlights the two different ways that we can access the SafeScript. I mean, in this instance, we didn't have any notifications when you went in to write the prescription, so you could just go in directly into SafeScript by typing the patient's birth date or their HIH number. In that way. But if there had been some sort of a previous prescribing or dispensing of that medication with a notification, you could have just clicked on that and gone straight in that way. So there's two different ways you can access the portal there.
Any questions from out there in COVID land?
Anna's winning on the face touching.
Oh.
Anna's winning on face touching.
I told you I'd have to sit on my hands. Sit on my hands. Goodness me, I've been caught out.
So we'll go back to the presentation.
Yeah. So we'll moving on now to SafeScripts in hospital. Again, if we can get our technology to work, flicking backwards and forwards through the two different screens that we've got. Yep, SafeScripts in hospital, that's the one we're up to now. So as far as accessing records in hospitals, at this stage we can't see any prescribing or dispensing records that are recorded from hospitals, but that is being worked on for future. But obviously the prescribers in the hospital can access the SafeScript portal, but it's not mandatory for the prescribers at this stage to access the SafeScript portal before they prescribe any prescriptions. However, from the 1st of April, it is mandatory for pharmacists, dispensing pharmacists, to check the SafeScript portal when they are dispensing medications on patient discharge or for outpatients, not for patients that are inpatients in hospital, because that medication will be supervised by medical staff. So that there's the difference there, and there is information for hospital staff on the Department of Health and Human Services website on the SafeScript information section there as well. So in future, it may well be that that we will be able to access the hospital records, but certainly when you are in the SafeScript portal in a patient's records, and if a hospital prescriber has accessed that patient's records, you will be able to see that they have done so. And you'll be able to see if they have had the medication dispensed at a hospital. So at least you'll know if they have been in hospital and there has been some medication initiated there.
So the permit requirements have changed as well, which is good news, I think. So when the department issues a permit now, it will be an ongoing permit, often without an expiry date, unless there are some concerns from the department. You actually don't need a permit anymore, provided the following things are met. So the dose has to be under that 100 milligrams of morphine equivalent. If you go over that 100 milligrams morphine equivalent, for example 50 milligrams of fentanyl, 75 milligrams per day total of OxyContin, you will require a specialist review and a specialist letter in order to obtain a permit, and that permit will often run for 12 to 24 months. Otherwise, if you're prescribing under that level and you check SafeScript every time you prescribe an S8 or any of those benzo S4s, you do not need a permit. The other couple of exceptions are when someone has been previously notified to the department as being drug dependent or previously on methadone or buprenorphine. You will need a permit at that point.
And I guess just to reiterate what Mark said, the regulatory requirements are that you can only view the patient's records if you are directly involved in that patient's care. And one of the other changes is that the date of birth needs to be put on the prescription. If it's not on the script, the pharmacist needs to enter it at the end of dispensing time. And also now that any patients that are on either methadone or Suboxone for methadone-assisted treatment for opioid dependence patients now have to record that prescription in the dispensing software. They don't need to record the daily administration, but every new script for the MATOD patient does need to be recorded.
Just a few other exemptions we've got on the screen. So a common note for all of these is that prescribing is very controlled. Prisons, police jails, aged care. I'm not sure they should all be grouped together quite like that. It's giving the wrong message in some way. Palliative care, where it's really end-of-life care, and often opiate doses are escalating. Palliative care teams are often involved in the care of that patient at home. Again, you don't need to have a permit for that. And you don't have to check SafeScript in that instance. And as we said before, prescribers in a hospital working from outpatients, because of the software issues, don't have to check SafeScript mandatorily at the moment, but prescribing from outpatient pharmacies where the scripts are taken out into the community, they do have to check and enter into SafeScript.
So one of the big issues is that we certainly need to maintain and manage patients' privacy. And if you recall the schematic that we had earlier with the circle and all the little padlocks in the middle, indicating that at each stage, each step of the SafeScript process, that the patient's information is kept secure. So again, it's only those people that are directly involved in the patient's care, have access to the information, keeping your login details confidential, as you saw Mark logging on earlier. Choose a login that you know, that you're the only one that knows what it is, and keep that secure. And we certainly need to counsel patients in private. I mean, certainly as a prescriber, that is generally simple because you are in your consulting room with the patient. In a pharmacy, it can be a little bit more challenging, so you need to have a private area where you can talk to the patient, and certainly make sure that you do have the patient's data, their date of birth, their name, Medicare details, all that correct, to ensure correct data matching with that. So what does it mean for the patient? For some patients, it can cause anxiety, particularly patients that perhaps are on opioid replacement programs, patients with mental health issues. So we do need to explain that to the patient. There is patient-specific information available on the SafeScript information hub, if you find that might be useful to help explain the situation for patients. And we just need to be respectful, non-judgmental with the patients, and certainly point out that the focus of the SafeScript program is safety of the patient, ensuring that they are not coming to harm from these high-risk medications, and emphasise that it is a clinical tool rather than something that we are using to monitor them. And there is the SafeScript, or I mentioned there that there is the helpline, but unfortunately that is unavailable in the short term due to the COVID-19 crisis.
So some patients do get very anxious about this, don't they? And they sort of see it as the patient-held electronic record. And I've certainly had a couple of people come in, "Oh, doc, can you just take that off for me? I'm not really comfortable with that being up there."
But
and
there isn't an
you
option
say,
in this.
sorry,
Yeah.
not an option. That's how it is.
It's not an opt-in, opt-out option. It's they do need to have it there. Okay, so that brings us to the end of the first session of our training session tonight, looking at the what, where and how of the SafeScript program. So we'll have a short break now, so you can all get up, move around, have a drink, do whatever you need to do, and then come back and our next session focuses on the high-risk medicines and clinical practice. So welcome back for session 2. In this session we'll be looking at high-risk medicines and clinical practice, and looking at undertaking a clinical assessment and how that can help distinguish the patients that have genuine need from those with dependence or those who may be seeking medicines for non-medical use. I'll hand over to Mark to talk us through how he undertakes a clinical assessment.
So I suppose when we're talking about a clinical assessment, it's worth, we'll just hop over to this slide, because obviously every situation is going to be different. So there's going to be patients like April that we've met before. They're going to be brand new patients coming in. There's going to be patients who are on these restricted medications for good medical reasons and have sort of lost control of them, or may not even realize they've lost control of the medications. So really, when we're doing our clinical assessment, we want to get a full good story. So we want a full medicine problem. We really want to know what the issue is that they're having the medication for. Is it an appropriate medication? Is the amount they're having appropriate? Is the medication escalating? And certainly when we're checking SafeScript, we can see if the gaps between prescribing is an appropriate amount and they seem to be using an appropriate amount. So when we're taking our history, and there's no need to teach any of you to suck eggs, we want that full, we want to know in our heads what the problem is that we're treating, and is the medication appropriate. As part of a full history, it is appropriate to take an illicit drug history, and often patients are very open to being asked about that. They may not tell us what they're actually doing, but nobody's offended if you ask. So you want to say, have you used this sort of medication before? How much alcohol do you drink? How much do you smoke? Do you ever use illicit drugs? Do you use marijuana? Do you smoke marijuana much? How much do you use? How often do you use it? Have you used any other illicit drugs? Have you used amphetamines? Do you inject amphetamines or do you smoke them? Have you used heroin or any other illicit opiates? It is remarkable how open patients are to asking those questions. So this is giving part of our whole picture. Again, if you have someone who has an existing substance use disorder, they'll be much more open to these questions. And especially if they're coming to see you to try and get opiates, they may be coming purely for help and looking to get onto perhaps the methadone Suboxone program, or just they don't know what's out there and they don't know what help is available.
Mark, and just as part of that clinical assessment, looking at risk screening and use of an opioid risk tool, is that something that you find useful?
So there's a very useful risk tool that has been developed. I'll just hold that up in front of the screen. Whoop, I have to go that way. Everything's backwards in here. So it just asks a few very simple questions and gives you a score at the bottom. It's worth just having, it's good to know about this in your head and just run through it, sort of almost at a subconscious level. So, does the patient in front of you have a family history of substance abuse? So if you have a family history of alcohol abuse, alcohol dependence, addiction, that gives you 1 point for a female, 3 points for a male. Illegal drugs in the family, 2 points for a female, 3 points for a male. Or prescription drug abuse history in family members. And again, that gives you 4 points for a female, 4 points for a male. It then looks at the personal history of substance abuse. Again, alcohol, illegal drugs, prescription drugs. And the more you have, the more points you get. And it gives you a risk at the end. Age is the same for both men and women, so between 60 and 45 gets you 1 point, because people younger than that are much less likely to develop a dependence. And over 45 it is more unusual, though getting less so as we all get older. A history of pre-adolescent sexual abuse gives women a 3-point score for developing a substance use disorder. It is curious that the research didn't validate that for men. And then, exactly as we see in a methadone clinic, psychological and psychiatric illness predisposes people a lot to dependence disorders. I know from working in a methadone clinic, and there's been a lot of research done on it, that across different clinics in different countries, over and over again, you find 80% of the clients have one or more diagnosable psychiatric conditions. And that includes the major psychiatric diagnoses such as schizophrenia, bipolar, then major depression. OCD is a risk factor for a dependence disorder, and just depression, anxiety. So I believe that in the clinic that I work in, almost everybody has an anxiety disorder of some sort. When you go into it with people in a non-judgmental way, you actually discover that a lot of these people that seem quite naughty, I suppose, and they really have underlying anxiety issues, and often social anxiety as well as OCD. So that gives you extra points for that. One of the things would be really good from tonight. So there's 3 goals from tonight. The first goal is to stop touching your face. But the second goal is to use SafeScript and know what it's about. And without being funny, the third goal would be to try and get across to you that people don't choose at the age of 7 or 8 to become dependent on different drugs. Nobody sets out, when I grow up, I'm going to be a drug addict. So it is often a result of life experience. And what happens for a lot of people is people become exposed to opiates, either licitly or illicitly, and suddenly it relieves all those horrible symptoms that they've been having from their OCD or their depression. I've had patients say it really quietens down the voices in my head. We see an awful lot of abuse in people's histories, so certainly in childhood, and that can be physical, psychological or sexual. It can also be just a neglectful history. So brother Johnny might be the golden boy that turns out to be the doctor, and the younger brother or the younger sister is always told they're never quite as good as Uncle Johnny, their brother Johnny. And so they have very poor self-esteem, and they have a narrative in their head that says you're not good enough, Mum and Dad never really liked you that much. And opiates are very good at settling this down. So this is all part of the clinical history. Now I'm being showed something to change the slide. So just going, so that's taking a full medicine history and being open. We'll come back to this sort of non-judgmental assessment.
So that opioid risk tool would be quite a useful thing to have as part of your practice policy. Looking at
it's good to have in your head, really, and you don't have to do it for people, but it's good to have there in the background. So then when it comes to physical examination, again, not going to teach you to suck eggs on this one, just observing the person, seeing their general state of nutrition, how well or not well they look, the colour of their skin, etc. But a really good thing to do is just take a blood pressure. And if you do it on their non-dominant arm, that's the best way to get a good look at the antecubital fossa. So, I have to do it like that in this screen. It's very tricky to do. And that is the most common site for injecting drug use. And if you see a little dark streak, you'll know that some injecting drug use has been happening. Or they have a history of leukemia and they've been having lots of chemo, or they're a really diligent blood donator. So we've been through these patient factors. So then when we come to drug-seeking behaviour, so you will see some people that are drug-seeking. So the important thing, as I've said, is to try and not frame this as this person is trying to con me, they're just looking to have a really good time, trying to get the best drugs for the nicest time they can have. Actually, most of them are self-treating psychological disorders. So it's good to have practice policies. So many practices will have a notice on the door about not prescribing benzodiazepines, not prescribing opiates, certainly not to new patients. And it's good to have in the practice a practice policy that can be referred back to. The idea is to focus on patients' well-being.
And because, as you mentioned, many patients may become dependent without realising that they have become dependent, and they do have the right to respectful care. And it's often quite good, for those complex patients, you may well need to allies with other allied health professionals and discuss with them, and certainly so that everyone's on the same page as to what the outcome for the particular patient is, and you want to develop and maintain a rapport and empathy with those patients as well.
So what we really don't want from SafeScript is people coming in, seeing the prescribing person, nurse practitioner, GP, doctor, and the person looking at SafeScript and going, well, clearly you've been having far too much of this stuff, you need to leave the surgery right now. What we want is we have more information now, we want to help patients recognize the issue, recognize that they're at risk of death from overdose. We want to work with those patients to set goals for recovery. So clearly they may not be in the stages of change where they're ready to start looking at that, but certainly giving them information and not just sending them on their way with a sort of click round the ear. That is not what we want. Yeah. And this is not what SafeScript is for. Yeah. It's for safety and to help people. Yeah.
The focus is on the patient's well-being, certainly.
So when it's talking in this slide about considering evidence-based non-pharmacological options, what we're really talking about here is if you're considering prescribing some of these opiates, you want to look at all the other management techniques first. So physio, chiropractic, exercise programs, acupuncture, education of the patient, look at the catastrophizing score, make sure that they don't think their life's over from an injury point of view. You want to consider all the evidence-based non-pharmacological options of treatment. We know now very well from opiates. Opiates are very good short-term painkillers. They are not, as we were told 15 years ago, good long-term management of pain. It is not a good way to do it. We know that long-term opiates stimulate glial cells, which are the cells between the neurons in the brain. We know that glial cell excitation stimulates the tracts that go up and down the spinal cord and actually turn the pain pathways into pain freeways. We know that lots of people on higher dose opiates actually have hyperalgesia, so they feel more pain than the person next to them who isn't on an opiate. It is very interesting to look at some of these legacy patients who've been on much higher dose opiates. As the opiate dose comes down, so the pain does not change. The pain does not get worse, but they become more active, more alert, more energetic, think clearer, and function better in life.
So it requires quite a lot of education
Yes.
for the patient, doesn't it, Mark? And it's probably not something that's going to happen in one consultation, but certainly it's something that will take time. Certainly patients have been on these medications for many years in a lot of cases. So it is a matter of educating them, giving them the thoughts, starting to get the idea in their head that perhaps it's not a good thing for them, that you will be there, you have their best interest at heart, and it is certainly for their well-being, their safety, and that the medication is in fact causing them harm. So we are focusing on the harms of the medication, not them as a bad patient, as you mentioned earlier.
So if we are going to prescribe these opiates to someone, first of all, we want to know we're prescribing for the right reasons, we're prescribing for an appropriate condition. It may be worth having a contract with the patient if you're going to prescribe these things, so that they know that they can't come in early, get extra scripts. If the dog ate their script, that's just too bad. A good way of minimizing risk and harms is the little the sentence, one prescriber, one practice, one pharmacy. People have to know that that is the appropriate way to manage these medications. And if you find on SafeScript that you have a patient that's seeing a couple of other practices, it is worth having a conversation with that patient. Look, we can see very transparently now if you're seeing other practitioners, the only way I'm going to prescribe this to you is if you stay with this practice only. The safety for you is to have one prescriber, one practice, one pharmacy. You certainly don't have to prescribe the entire amount that's on a prescription. So I know the default level of oxycodone, endone, is 20 tablets. If you give 20 tablets, 3 tablets a day, that's a week of endone. We know that one script of endone or one script of OxyContin, and you have a 3% risk at the end of the year of still being dependent on that medication. We know at the end of 2 prescriptions that your risk jumps to 12 to 13% of being still on an opiate at the end of the year. So smaller quantities, stage supply. Stage supply means writing on the prescription. So instead of giving them 28 OxyContin tablets or 28 MS-Contin tablets, certainly give 28, but say dispense 14 weekly, or perhaps dispense twice a day on Mondays and Fridays. That's staged supply. It can be awkward for the pharmacist, but most pharmacists worth their salt are happy to do this because of the safety issues, and it keeps, although we're taking some of the control from the patient's clients, the patient clients often appreciate it, and it stops them having temptation in front of them.
And just on the point of stage supply, there is funding under the 6 Pharmacy Community Agreement to actually assist with that stage supply as well there. And just on the point of the not having to prescribe the full box of 20 endone, the recent TGA recommendation to use smaller pack sizes, particularly for the acute pain. That's sort of the rapid acting or rapid onset oxycodone, the endone.
Yeah.
Using those, so don't prescribe the full amount. You don't need to give 20,
Yeah.
just 1 or 2 days supply.
On the other hand, if you do have someone who's dependent or using regularly for several months, a long time, say 10 milligrams MS-Contin TDS, it may be reasonable to get an authority prescription for a larger amount, but put on that prescription, please dispense once a week from X pharmacy. Just one other point that's worth noting is that it is interesting, OxyContin and MS-Contin, both of them at those lower doses, 5 milligrams, 10 milligrams, are often TDS medications, and I've seen a number of patients who've been running into trouble because they've been going into withdrawal at about 6, 7, 8 hours, whereas their dispensing is only twice a day. So it's worth actually dropping the size of the tablet and going to TDS 3 times a day prescribing for those patients. Take home naloxone. So as we know, if you're over 100 milligrams morphine equivalent, you're at quite high risk of overdose. Naloxone is a very readily available medication now that patients can have in their home. So we can prescribe it. It's if you type it into the prescribing software, you'll see that you can actually prescribe it under the PBS available from pharmacies. People can buy it over the counter at pharmacies, and most needle syringe establishments in Victoria and the PABINs, which are organisations to help with opiate management, will actually train and give naloxone out for free to people on 100 milligrams morphine equivalent. It's a really good thing to do, and it makes the patients who just think, oh, I'm just on this medicine from my doc, Mabel's got a sore knee, I might give her one of those tablets. It really makes them think about the fact that they might overdose from that, and naloxone will reverse that. If you give naloxone to someone who's not on opiates, it won't do anything. It's perfectly safe medication.
And as Mark said, there are places where you can obtain the naloxone at the Ballarat Community Health Centre. The harm minimisation coordinator there, Pauline Malloy, pharmacist with many years' experience in dispensing methadone, she is available there to talk to practices and also supply the naloxone to patients there.
And for you folks not in Ballarat, we have an equally good system here in Geelong. And we have a team as part of the outreach team who will come and do training and actually deliver naloxone to your home. And this is time for my show and tell, and I think I deserve one itchy nose. Oh, that's better. Right. So you can prescribe Prenoxad. So Prenoxad is naloxone. It comes in a syringe. So the syringe is graded with 5 doses. If someone gave all the doses, it wouldn't matter. You can't overdose on naloxone. It does come in the box with a syringe and a needle. So you can just give it into the thigh intramuscularly. The very important thing to remember is if you're on a long-acting opiate, especially something like methadone, the half-life of this is much, much shorter. Maybe 1 to 2 hours, methadone 37 hours. So it gives the patient, the client at home, time to call the ambulance and get help. It also now comes as a magical nasal spray, which is really good for patients. because they don't have to give needles, inject anybody. You just spray it up the nose. The instructions are on the back, calling the ambulance, injecting it up the nose, putting them in the coma position. We have a question come in. That's my show and tell.
Before we move on to like the next section talking about tapering, we'll just let Mark answer the question that's just come in.
Dr. Ahmed asks, can I open SafeScript sites in front of patients? Absolutely, if it's their SafeScript. So if it's about them, no problem at all.
Yep.
If you leave SafeScript alone, it will close by itself. I think it's a really good thing to show patients their SafeScript record, and it shows them that they can't go from doctor to doctor, and that it helps them stay on the straight and narrow in a way.
And it may actually make them aware. They may not have realised, in fact, how much of the medications that they are using. So it might be a real light bulb moment for them. So certainly patients are able to see their own record. Then just...
We're going to talk about tapering.
Tapering, yeah. So tapering schedules depend on the patient, the medication, the doses, the duration of use.
So tapering works really well. I certainly had some of my own patients that when the drug reps were coming around and saying there's no addiction with opiates if you have pain, and if you don't get rid of the pain you're morally bankrupt. So I ended up with a handful of patients on quite high doses. So tapering is a slow process. The longer the person's been on the relevant medication, the slower it should be. If we look at tapering benzos first, this is the benzodiazepine toolkit. So there's an organisation in Melbourne, I think it runs out of Malvern, Reconnection. Some of the practitioners that have been around for longer may remember Reconnection as Tranks. So they offer counselling to patients. They offer face-to-face counselling or on the phone counselling, much more relevant of course these days. They offer supports to relatives of people on benzos. There's a lot of information on their website, what to expect from reducing benzos, what the withdrawal can be, how to stabilise the dose, and they're happy to send out to all practitioners the benzodiazepine toolkit once it's requested. So
that's a really useful resource there that's available both for health professionals and for patients as well.
Can we blow this screen up as well?
Yeah, this table just talks about the dose equivalence of the benzodiazepines, the equivalence to the diazepam dose. So if a patient is on more than one benzodiazepine, it's generally recommended that you convert the dose to diazepam and look at tapering down from there.
Absolutely. So quetiapine has actually been problematic as well, and that's why it appears so often in SafeScript, or why it has appeared as a recommended medication in SafeScript. These are the recommendations coming out of Turning Point for tapering quetiapine. As we can see, try to reduce 25 to 50% every 1 to 2 weeks and cease after 2 weeks on the minimum dose.
And again, if the patient's been on a high dose for a long time, you can do a slower taper to try and minimise or avoid those withdrawal symptoms from occurring.
The interesting thing about Seroquel quetiapine is often the punters, shall we call them, that are using it inappropriately are trying to get a higher sedative effect, and we know that the antihistamine effect is up to about 150 milligrams. So really, prescribing for more than 150 milligrams doesn't do that much. It does have a mood stabilizing effect that goes up, and then the antipsychotic effect is felt to be at a much, much higher dose, about 500 milligrams plus. Tapering opioids, so we want to taper 5 to 10% every 2 to 4 weeks. So I found in my practice what's actually very useful is doing it once a month. And look, it may take 6 months to a year. These are my patients. If you're seeing someone new, say their previous practitioner has retired and you suddenly got this legacy patient, then it may be worth doing a big jump at the beginning but then reducing much more slowly. Here are a couple of good examples. So we know as we get to the much lower doses, we have to slow down the rate of reduction. But reducing by 10 milligrams per week to 50, but we could even do that a bit slower. If someone's been on it several years and you're working with them, so 100 milligrams daily, so they might be on 50 milligrams twice a day. So you might go 40 milligrams, then 40 in the morning, 50 in the evening, obviously. But maybe do that change every 2 to 4 weeks rather than actually doing it once a week. You have to be guided by the patients, and sometimes you will have to hold the withdrawals and just hold it until people feel well.
And there are some good resources available to help GPs explain this to their patients, and also some good tapering resources for health professionals on the NPS website, and some good consumer information as well. And also the Pain Management Network that's on the screen now, they have a lot of good information there. So if you're looking for some more information or handouts you can give to your patients to talk about what's going on as far as decreasing their opioid dose, there's some good places there to get some support for yourselves.
I might just go back one screen as well, just to fentanyl. So reducing fentanyl, they do make a 12.5 microgram patch, so making up doses of 2 patches such as a 50 and a 12.5, and trying to reduce by approximately 12.5 per month or every 2 weeks. I'm not really sure there's a place in general practice for fentanyl patches anymore. They're very, very dangerous. There are many, many overdoses. They have a high street value. People love selling them. They love extracting the fentanyl. I had a young heroin user the other day saying the heroin was really good at the moment. It's really strong, and gee, it's lasting a long time. So one dose seems to get me through the day. So that makes me think it's actually cut with fentanyl or something else rather than pure heroin. So
the TGA has also made new recommendations in relation to fentanyl that should only be used for, I think, palliative care, cancer pain.
Tell me more. I haven't
palliative
been across
care,
that.
Cancer pain, and extreme circumstances.
Yes,
so
completely appropriate.
So certainly looking at sort of decreasing the use of fentanyl, as you said, in general practice.
This is actually a tapering calculator, and when you put in the different, you can put in the different doses of the different medications into this calculator. It will convert it all into a morphine equivalent, and it will tell you what doses to give depending on what rate you want to reduce. It's been a very useful tool. It's a good tool and worth having a play around with in an experiment at home.
So now we have another video for you. This one is a video developed by the Hunter New England Pain Service. It helps explain the pain process to patients and what other alternatives are out there to help with their pain.
So this is a great video. So I get very excited about this video. There's 3 videos in the series. They're all about 5 minutes long, and they're just terrific. So you're very lucky that you're going to watch this one. And what a really good thing to do, I've actually bought a couple of speakers for my computer on my desk in my general practice. So I might sometimes sit the patient down and just leave them watching this while I go and grab a cup of tea and come back. Patients love it, and it gives a really good summary of what's going on. Another good one to write down, if you've got a pen in your hot little hands, if you're not eating dinner and having a glass of illicit drugs, alcohol, is Taming the Beast by Dr. Lorimer, who's a very articulate and good speaker on pain. So Taming the Beast. And these are the Brain Man videos. So you type into Google Brain Man pain and they'll come up with them. So off we go.
Everyone agrees that pain is a universal human experience. We now know that pain is 100% of the time produced by the brain. This includes all pain, no matter how it feels, sharp, dull, strong or mild, and no matter how long you've had it. You might have had it for a few weeks or months. This is called acute pain, and it's common with tissue damage, say from a back injury or ankle sprain. And generally, you'll be encouraged to stay active and gradually get back to doing all your normal things, including work. Or you might have had it for 3 months or more, and this pain is generally called persistent or chronic because in this type of pain, tissue damage is not the main issue. What's less clear, though, is when you're told you have chronic pain, is knowing what's best to do about it. Well, in Australia, chronic pain is a really big problem. In fact, 1 in 5 people have it. Having a brain that keeps on producing pain, even after the body tissues are restored and out of danger, is no fun. Some people say it still feels like they must have something wrong. But that's just it. Once anything dangerous is ruled out, health professionals can explain that most things in the body are healed as well as they can be by 3 to 6 months. So ongoing pain being produced by the brain is less about structural changes in the body and more about the sensitivity of the nervous system. In other words, it's more complex. So to try and figure out what's going on, you need to retrain the brain and nervous system. To do this, it's helpful to look at all the things that affect the nervous system and may be contributing to your individual pain experience. What can help is to look at persistent pain from a broad perspective, and by using a structured approach and a plan, it's less likely that anything important will be missed. Let's start with the medical side. Firstly, taking medication can help, but only to a limited extent. It is the more active approaches that are necessary to retrain the brain. So using medications to get going is okay, and then mostly they can be tapered and ceased. Some people also think surgery might be the answer, but when it comes to a complex problem like chronic pain, surgery may not be helpful. So if you're thinking of surgery, it's best to get a second opinion and remember to consider all the things. Next, it is helpful to consider how your thoughts and emotions are affecting your nervous system. Pain really impacts on people's lives, and this can have a big effect on your mood and stress levels. All those thoughts and beliefs are brain impulses too, but you can learn ways to reduce stress and wind down the nervous system. This helps with emotional well-being and can reduce pain as well. The third area to consider is the role of diet and lifestyle. Now, it turns out that our modern lifestyle might not be so good for us. In fact, what we eat and how we live may really be contributing to a sensitized nervous system. Looking at all the things like smoking, nutrition, alcohol, and activity levels, and seeing if there are any issues is a good beginning, and these things can go on your plan. Then there's often enormous value in exploring the deeper meaning of pain and the surrounding personal story. By stepping back and looking at all the things that were happening around the time the pain developed, many people with pain can make useful links between a worrying period of life and a worsening pain picture. For many, recognizing deeper emotions can be part of the healing process. Last, but by no means least, is physical activity and function. From the brain's perspective, getting moving at comfortable levels without fear and where the brain does not protect by pain is best, and you'll gradually restore your body's tissues. So, to sum up pain, it comes from the brain and it can be retrained, and when looked at from a whole person or broad perspective, gives you a lot of opportunities to begin. So, get a helping hand if you need it, set a goal, and begin.
So I'm sure you found that very interesting, as well as something useful that you can use with your patients, just to get them to start thinking about other options for their pain, not just medication. Now, moving on, we're just going to be talking a little bit about MATOD, the medication-assisted treatment of opioid dependence.
So MATOD is certainly an option. It's a bit of a sudden change of direction from what we've been talking about, but we know that both methadone and buprenorphine or Suboxone work as well as each other in the treatment of opiate dependence. We know that if you put 100 people who are using heroin on methadone or buprenorphine, that 60% of those people will stop using within a week and will continue not to use while they're under treatment. We know that 10% per year get off methadone and Suboxone. So some people say, oh, you're just replacing it with something else and they're just going to be on that forever. That's not actually true. And what it does, it allows people to sort out their lives. So it allows people to become parents properly, get jobs, get their life in order. It's an enormously successful treatment. The legislation was changed in the face of all these overdoses and the codeine abuse. So now any GP can prescribe Suboxone. So Suboxone comes as a strip. It's for up to 5 patients. The strip has buprenorphine in it. It comes as a 2 or an 8 milligram strip. So a 2 milligram is probably equivalent to the 40 microgram patch. So just try and have that in your heads. But we tend to find that the sweet spot is somewhere between 8 and 16 micrograms. 8 to 16 milligrams, which is 1 to 2 8 milligram patches. In very, very successful treatment for codeine dependence. So all those patients that have got themselves into a mess taking Nurofen Plus. So a study done before the legislation requiring it to be prescription only discovered that in Adelaide, people presenting to a drug and alcohol clinic for help with Nurofen Plus addiction, the median number of tablets taken in that study was 60 tablets a day. So that's a box of 20 for breakfast, a box of 20 for lunch, and a box of 20 for dinner. The range went up to 120, so 2 boxes for breakfast, etc. And yes, they did have stomach ulcers, they did have renal failure, they did become anemic. So I think 80% of the people in the study were anemic from gastric blood loss. Anyway, Suboxone, fabulous treatment. It's a little bit tricky, so good to seek help if you're doing it first time. There's a good guide on the department website, a brief guide to how to prescribe it, but there are doctors and people to assist in every part of the state in Victoria through the PABINs, and certainly you can contact them through, in our area, the West Vic PHN, and someone will help you prescribe it if you have a client you know well and that's really what you want to do for them.
There's also, I think, RABS, the Rural Addiction Medication Pharmacotherapy Service, I think, as well, and Project Echo, and on the DACUS website as well. So as part of the SafeScript program, each PHN has a GP clinical advisor that you can contact through through SafeScripts, and
flick ahead to that.
They will help you with any questions that you have in relation to that. And just like talking about the Suboxone again, any pharmacy can dispense it. They just need to apply for approval. And there is online training as well through the PSA if there's any information that's required for that as
and
well.
Health Pathways has an excellent summary.
So there is a lot of support out there, and we really do need more MATOD prescribers and dispensers, because those GPs that do prescribe it are really under the pump. Yes, Mark in particular. But yeah, certainly around like the PHN, those handful of GPs that do prescribe the opioid replacement medications, they have more patients than they can actually see. So certainly think about undertaking that training and becoming a prescriber.
Yeah, how exciting. We've got another case.
So this case study, this time we have June Jones. Now, June's come to see you, Mark. You are Dr. Safe. So she is one of your regular patients. You've seen her for 5 years, about every 6 months. She has a general anxiety disorder, and she's been on clonazepam 0.5 milligrams twice daily PRN for 2 years for her anxiety. So she has come to see you today, I think, for her for a 6-monthly review.
So yes, the 25th of January 2019. A different world back then, wasn't it? And she's on clonazepam, so 0.5 milligrams of clonazepam, equivalent to about 5 milligrams of diazepam, so she's on about 10 milligrams of diazepam per day. Just out of interest, we know that if you have 1 5 milligram diazepam per day, you double your risk of a car accident. If you have 10 milligrams of diazepam per day, you have 4 times the risk of a car accident, because it really affects your cognitive ability. Which interestingly doesn't happen with opiates. So if you're on long-term opiates like methadone or the other opiates, it's been shown that cognitive abilities, once someone's on a stable dose, remain the same, and there's no actual increase in the risk of driving. The risk comes with changing dose, but not on stable doses. So we're going to log in. We used the PIN we had was 441144, and as you can see, it's left me logged in. So 441144, bing. So we're in April Adams. We'll go up to search. So we change this to June Jones. Date of birth was 2nd of February
1980.
1980.
And this will give us the last 8 entries of June's history in SafeScripts.
So we can see June Jones there. And what have we got? Okay, we've got a red alert here in the corner. So if we click on that alert, it will tell us what the alert is about. June Jones has obtained prescription medicines from at least 4 different prescribers within 90 days. Take action to coordinate treatment to ensure patient safety. So let's just close that alert. So we'll just have a quick look at prescribed. So we thought June Jones was just seeing us for her 6-month script and seeing us once every 6 months, but it turns out that yes, Dr. Safe, I did see her in November. But what's this? She's seen Dr. Brown in December, Dr. Black in January, and Dr. Green also in January. So it looks like her use is escalating. So if we actually look at all events, we can see, sometimes it's a little bit fiddly, we can see that my prescription prescribed on the 19th of the 11th, so we go down to the bottom, was actually dispensed a day later on the 20th of the 11th. It actually gives the date of the data hitting the central database. So every time I write a prescription from my computer, that information goes to the central database immediately and appears in SafeScript within about a minute. Same for the pharmacists. We can see that the next prescription was done the 2nd of the 12th, and that was dispensed on the 2nd of the 12th. So it was 14 days between those 2 dispensings. That's 7 tablets a day. So she's on the equivalent of 35 milligrams of diazepam a day. We can see from the next gap the Dr. Black's prescription on the 12th of the 1st, which was actually for diazepam this time, was prescribed a day later on the 13th. I've just skipped Dr. Brown's, which was prescribed on the 12th and dispensed on the 12th. Diazepam was given by Dr. Black, and then Dr. Green gave diazepam again. So clearly we have a problem, or June has a problem.
So what are we going to do with June, Mark? Or Dr. Safe?
Dr. Safe.
Dr. Safe, she's come back to see you for her 6-month review of her clonazepam, which rather than using it 1BD PRN, she's been using it
so
much more.
Should we say June, I'm very disappointed in you. You've clearly been lying to me all this time. I've trusted you. You just need to take yourself out of this practice and go away. Is that a safe thing to do if she's on benzodiazepines for this long at that amount?
I don't think so. Absolutely not.
Is quite likely, abrupt benzodiazepine withdrawal is quite likely to result in fits and severe withdrawal symptoms. So SafeScript is a tool, so it's not a good idea to refuse to prescribe, but just because we are going to prescribe doesn't mean to say we're going to do anything like we were doing before. So really the sensible thing would be to change over to diazepam, work out an equivalent dose of diazepam, work out a dose reduction that's probably safe to do. So she's on about 25 to 35 milligrams of diazepam, so perhaps we ought to go to 15 or 20 for a couple of weeks. Give her the prescription, probably twice a week dispensing, 3 times a week dispensing, and then start reducing by 5 milligrams or 2.5 a week or 5 milligrams a week until we get down to a much safer range, which would be back to her original sort of 5 to 10 milligrams. The good goal for June would be to get off all benzodiazepines. And we know benzodiazepines, even at low dose, affect short-term memory. So the most memorable, that was an accidental pun. The most memorable case I've had of that was a lady who was on quite long-term high-dose benzos. We eventually got her down to 5 milligrams of diazepam. I wasn't too fussed about her being on 5 milligrams of diazepam, given where she'd come from. But she did eventually get down to a 2 milligram and then off it, and then came in and said, oh my goodness, I can't believe the difference. I used to put my keys down, I could never find them. I was always ruffling about in my handbag. There were things in my handbag I didn't know they were in there. I was always losing things all the time. I always missed appointments. And since stopping that last diazepam, my memories come back to normal.
Yep.
Really a huge learning experience for me.
That's it. And I think patients are not necessarily always aware of how
Yes.
the medication
Yeah.
is affecting them. That has become their new level of normal, and they just think that's how it is, that's how I am, and that they are fine, and they don't notice the difference until they are medication free.
And often people on high doses of benzos don't really realise how they appear to the person in front of them. So I've had a number of patients in the opiate clinic, in the methadone clinic, who've been accessing benzos from the street, and they come in and you can tell they're sort of glazed and far away and a bit all over the shop, and you go, look, I have to say you seem a bit stoned today. So I do actually say that, and they go, oh doc, no, oh, I didn't get any sleep last night, it was just terrible, no sleep last night. And then you see them perhaps 2 or 3 weeks later and they're not on the benzos from the street, or they're on their a very small amount, and they're coming, oh yeah, sorry doc, look, I'd taken a handful of Xanax before I saw you. It's interesting, if you see people on too much benzos, they're often groggy and far away and a bit confused. If you see people on too much opiates, they're often quite sleepy, but then when you ask them questions, they wake up and give very rational, coherent answers, but then fall asleep again. So I had a very memorable occurrence only last week, crossing Latrobe Terrace in Geelong, and the person in front of me scooted across the first half of Latrobe Terrace, and I was waiting behind, so I scooted across, stand next to him, and he was falling asleep waiting to cross the second part of the road. So I actually tapped him on the shoulder and said, oh mate, are you okay? And he, oh yes, woke up and went, oh, I didn't have any sleep last night. Very difficult not to smile.
Typical patient of yours. Yes.
Anyway.
So back to June. So with her, again, it's sort of that similar thing of one prescriber, one pharmacy, staggered dispensings, whether it's a short-term prescription, a management plan, and I think that's very important that you mention. What is the goal? This is what we're actually working towards, so the patient realises, that this is where we're going, so that they can become active in their own management, and whether it's a matter of having more regular appointments with their GP as well, just to see how they're going, and they need to feel supported by their GP, not to feel that like I'm a bad patient, but again, that empathy and respect coming through, and that the patient feels supported.
All right, so I've just clicked on View Alert History, and that shows that June Jones has one alert there, and it's a high risk level. So we'll go back to the PowerPoint, but we've discussed all the next few slides, so we're just up for another break.
Before we go on to a break, Mark, we have another question that's come through.
Right. Dr. Ahmed goes, quetiapine in nursing homes, this drug is prescribed for behavioural issues, and a patient can be on this medication for many months or years. What is the indication to decrease? So that's a complex problem, because you've also said that nurses are reluctant to reduce as the patient is stable on this drug and it has been prescribed by a geriatrician. I think you, Ahmed, need to sort of own this problem yourself. Do you feel it's an appropriate medication for this patient? Is the dose appropriate to the patient? Is the patient being sedated just so that they don't make a fuss for the nurses? We know very much in nursing home patients that activity for patients, keeping them engaged and active, appropriately managing sleep, not letting them have 2 cups of tea just before they go to bed, they're much better approaches to using medication. So you have to really look at each case on its own merits.
Just in addition to that, Mark, that firstly, quetiapine is not actually indicated for behavioural and psychological disturbances in dementia, and for patients that are having any kind of antipsychotics for managing their dementia, that it is a recommendation that is reviewed, and ideally, like the dose step down every 3 months at least. So it does need to be reviewed every 3 months. And what you mentioned about the non-pharmacological management, looking at the triggers for the behaviour, that certainly needs to be something that's sort of discussed with the staff. What are the triggers for the behaviour, and what kind of non-pharmacological management options have they got that they are using prior to using medications?
Yeah, that's fantastic, Anna. Thanks. Okay, we'll go to a break.
Welcome back. Now we're on the home stretch now, so we're looking at the third session, and this is going to focus on challenging conversations. Now, a lot of the things that we, I suppose, just will quickly touch on, Mark's already spoken about in the various case studies and things that we've spoken about already. So if we're looking at those challenging conversations, I guess it's just, to look at or get you start thinking about or to outline what kind of approaches that you think might help with those, help the patients recognise that the medications may be an issue for them, and how to help motivate them to change their behaviour. So that's the difficult part.
So the patient's readiness to change, I'm sure we're all familiar with the stages of change model, and trying to identify where the patient is on that stages of change. Certainly at the beginning of that cycle, giving them information, so teaching them how dangerous these medications can be, that people can develop dependence, that withdrawal is a real issue, that some people do find them very helpful for other psychological conditions, but that is not helpful in the long run because it can lead to dependence and addiction behaviour.
So a lot of it depends on, I guess, what are the patient's wishes,
Yeah.
what is their life circumstance, what is their health choices, looking at all those sorts of things. But it all comes down to, as what Mark said, what is their readiness for change.
Yeah.
So, and again, that's probably something that's going to take quite a long time.
And I hope today we've got across that people don't choose to be in this situation. So we want to really avoid stigma, and we want patient-centered shared decision making.
Yep.
That we know that decision making where we make the decisions just doesn't work.
Yep.
You need the person on board, and you need to know what part of readiness to change they are. So avoiding stigma is very important. So trying not to talk about addiction, but you have a physical dependence. And
evaluating the treatment. So we're evaluating the treatment, saying the treatment's not working. It's not the patient that's the problem. It's the treatment, and that's sort of putting the focus on that.
Yeah, absolutely. So motivational interviewing is certainly a good technique. So resisting the writing reflex to try and tell patients what's what. Understanding the patient's motivation, own reasons to change. So trying to elicit from the patient why they might want to change and what their motivations might be. Listening with empathy, so trying to listen, and these days the training younger doctors and prescribers, nurse practitioners get is very good on listening with empathy and using appropriate body language, not being defensive, and listening properly.
Trying to work out from the patient what it is that will actually motivate that patient to take those first steps in change.
And lastly, empowering the patient, make the patient the person in charge. So I always try and say, well, these are things I have to do, and this is what I can do for you, but at the end of the day, it's your decision where we go with this. Motivational interviewing, another thing is OARS, open-ended questions. We're all taught open-ended questions. Just on a quick aside, I try and teach the medical students some closed questions these days to try and end consultations when they're going forever. Affirmations though, so certainly in this situation, what open-ended question? Affirmations, yes, I am hearing you. Reflections, so summarising back to people what they've told you and checking in with them, saying, is this what you've told me? Have I got this right? Is this what you're saying?
So we're certainly encouraging the patient to talk, to sort of get their fears and thoughts and feelings out there, sort of where they're hoping to go. The patient, dealing with patient resistance. Now that's obviously a very, very difficult part, challenging for the GPs.
So again, this is what we've been talking about all night. I mean, sometimes, there will be patients that really don't want any help. They just want their drugs, and they want to get out of there and get their drugs and get their psychological relief or their hit. And sometimes the course of best action is to give them a very small amount of the drug that they're requesting, like literally 1 or 2 tablets. And if you do that, you won't have an explosion in the practice and they'll go elsewhere next time, which is not great, but that's sometimes the reality of life. One day they will connect with someone and they'll be in a position when they're ready to change. Giving information, because the level of knowledge out there is actually very low often. Many people don't realize they have a substance dependence, or I remember a young football player that I see, and he basically had a knee injury, was given 20 endone to help manage his knee injury, found it helped his underlying social phobia and general anxiety disorder enormously, found that he could go to the club much more easily if he'd just taken an endone, and in fact going to the club and then playing with an endone seemed to work much better. He was able to access a ready supply off the street, so kept using it, and it was only when he went on holiday to Bali and decided to leave all the tablets behind because he had enough of them and went into crashing withdrawal on his first 24 hours in Bali that he realized he had a substance abuse disorder and a dependence. He caught the next flight back from Bali and is now managed very successfully on Suboxone.
And many patients may feel that if they're taking a medication that's been prescribed, it's therefore safe and they won't develop a dependence or an addiction or anything like that.
Comes back to the education. And then using naloxone and talking about it.
Yeah, and often may well be useful to provide some sort of written information that the patient can go home and read over and think about, and then have a further discussion at their next visit with their GP.
So we have another case.
So this time we have Michael May, who has presented to the pharmacy this time. So this is the first time that Michael has come to this pharmacy, and he's presenting a prescription for OxyContin 40 milligrams quantity 28. The pharmacist is familiar with the doctor who's written the prescription, as she works in the clinic nearby. So we assume that the date of today is the 21st of January 2019. So if Michael has come in with his prescription for OxyContin and the pharmacist has put his information, put the prescription into into the dispensing software, and then gone to check SafeScripts, and the SafeScript record shows us that.
So it's searching Michael.
And he's got quite a few items listed, and he's got some alerts showing up there as well, the red triangles on the left-hand side.
Or even the orange dots.
The orange dots as well.
It's all right. Anna's got the black and white copy. Poor thing.
It's teeny tiny.
Oh.
It's teeny tiny writing too. Even with my glasses on, I can't read it.
So if we go to SafeScript and we're looking at Michael's screen here, we can see right down the bottom, in August, Michael had 20 endone prescribed by Dr. White. And that was dispensed a day later, on the 16th of the 8th. But then we can see from the record there's a whole bunch of dispensed prescriptions without the prescriber showing. Now that's likely to be a doctor in the hospital, outpatients, pain clinic, emergency department prescribing. And because of their software, they don't have easy access to SafeScript, so they're not able to go, oh, Michael's getting a lot of this stuff. So we trigger our first orange alert in December. So we'll just click on that orange alert. Records within the last 90 days indicate that Michael may be receiving opioids in exceeding 50 milligrams medications daily. There is an increased risk of opioid adverse effects, including overdose and harm. Counsel the patient on possible adverse effects of opiate use and the risk of further increases in dose. So it was about this time that it seems that Michael's use was starting to escalate. We can see that he was dispensed. Now we'll just go back. So on the 12th of the 12th, he had 28 oxycodone. 12 days later, he had OxyContin, 12 days later, he had accessed another 28 days of OxyContin. And then on the same day at a different pharmacy, at the same pharmacy, he also, that's a bit confusing, isn't it, actually?
He's got different OxyContin prescriptions. He's got 40 milligrams, is it 60 milligrams? So he's got a number of different strengths going on as well.
So he's having, when you work out the time difference between the different dates of dispensing, he's having about 4 tablets a day. So he's having about 160 milligrams per day of oxycodone and OxyContin. We can see that then he got some endone, and finally from Dr. Black. And so he's presenting to you, the pharmacist, with this history. So, what does the pharmacist do next?
Well, you would need to discuss with Michael the reason why he's seeing so many prescribers, what his actual pain is, what he's hoping to, what he's managing with the different prescriptions that he's taking, when is he taking them, how often is he using the different ones, and is it actually helping with his pain?
But we can see he's got a problem, can't we? Because this
Absolutely.
is the 21st of January, and yesterday he got 28 of the 20 milligrams. And now he's come back one day later to get 28 of the 40 milligrams. So either he's using a lot, or perhaps he's even diverting and selling it.
He could
That would
well
be another possibility.
That could be a possibility, absolutely. So,
What would be a good option as a pharmacist?
Well, in this instance, you would probably be a good option to contact the prescriber, particularly like, you know, she's just around the corner, and you have a good relationship with her, you know her well, so give her a call to see what she knows about the patient. She might know a lot more than you do, and the reason that she's prescribed this medication for him, just to see what other background information you can find.
And what happens if the prescriber's not available and there's nobody else in the clinic prepared to talk to you at that point?
If the prescriber's not available, and that often it happens, it might be an evening, it might be a weekend, a public holiday where the prescriber's unable to be contacted. So you may not feel comfortable with prescribing or dispensing the medication.
So there's a couple of ways to go, I suppose, aren't there?
Certainly.
So there are no hard and fast rules. So you could say, look, I'm going to give you enough till tomorrow until I can talk to the prescriber.
Because you certainly don't want to leave the patient with no medication if they have been using it long term, but you don't want to be giving them a whole packet of it either. So it might well be
you could
1 or 2
show
days
them
supply.
Yeah, you could show them their SafeScript. You could show the patient what's in front of us right now and say, well, Michael, you had 28 tablets yesterday. So what do you suggest I do about that?
Yeah. And explain to me, why do you need, you know.
And often patients will be very upfront. Before SafeScript, we did have one patient at our practice, and I'd heard from another patient that he was selling his medication, so I discussed with the other prescriber that this might be going on, and so we managed to organise for him to do a urine drug screen, and it turned out there was no opiates in his urine drug screen, and whereupon the practitioner said to the patient, oh, look, this is pretty difficult actually. There's no opiates in your bloodstream, so I don't really feel I can prescribe you anymore. And with a fair degree of anxiety and wondering what was going to happen, and the patient actually said, oh well, okay, doctor, and left. And that was the end of the story. It was very interesting. And then when he got very sick, about 6 months later, came back because he felt that the doctor had done the right thing and was an honourable person. So often, when faced with black and white truth like this, often it's very easy to negotiate with people.
And I guess it comes down to the approach that you use with the patients. Use that non-judgmental, non-threatening manner, and just to say, well, these are the facts, and I'm trying to help you here. I'm concerned about giving you this amount of medication.
Absolutely.
because the harms that it may do. All right, so just moving along now to, I think, just wrapping up the session today, really. So we just sort of cover over what we discussed, like that the SafeScript information, just the access to SafeScript is only for prescribers and pharmacists directly involved in that patient's care. No patient permission is required, and there is no patient access to their SafeScript record. They can't access it directly. We can certainly show their record to them when they are with us, having a consultation, but they do not have any direct access to it, unlike their electronic health record. So I guess that sort of, they may feel that, you know, a little confused about that, thinking one is the same as the other or works in the same manner. So it's just important that everyone that will be required to use the SafeScript portal is in fact registered by the 1st of April. So you've got a few days up your sleeve to get your registration complete. So it may take a little bit of time, that initial registration, but it's fairly straightforward, and once you've only had to do it, you only have to do it once, and once it's done, then it's plain sailing from there on. So, and if you do need further information, there is the SafeScript Training Hub. They have like videos and then information both for prescribers, for patients, for dispensing, for patient information, the health professionals working in hospitals, and if you're looking at how you actually load get the SafeScript to work in your prescribing and dispensing software, there's information there to talk you through those. So there's a lot of information there if you feel that you do need more, and your local PHN is always a good port of call if you do need more direct information or assistance with actually getting it to work in your clinic.
And here we have some of the actual websites and technical support up on the screen. And the PHNs are very helpful for this, particularly with this sort of thing. Yeah,
so certainly just, and remember there is the IT support if you are having difficulty getting it to work, and just to remember that the hotline is not available just in the short term with the current COVID-19 situation. So there will be an evaluation form that's required, and the
Have we got any questions?
Oh yes, certainly. Is there any more questions that anyone needs to submit while we're still here? Yeah. Okay, gone, I think, on that. And just if you just want to check the screen now, there's information about how to get your CPD activities for this session that we've had today. So email to the SafeScript training at westvicphn.com.au and provide your details there, and then you'll be sent an evaluation to complete, and following that you'll get your certificates. Thank you very much. Thank you to all those who dialed in to participate in the session today. Thank you very much, and stay safe.
Who touched their nose the most?
Oh, I'm sure it was me.
I'm sorry, and I just like to demonstrate how Anna and I are socially distancing. So as if we get closer and closer and closer, then we just disappear.
We disappear. Magic tricks.
Magic tricks. So have a good evening, and I hope things go well in your practices. Okay.
Thank you very much.